Good morning, everyone. So I'm Dennis Falzon. I'm a team lead at the Global Tuberculosis Program here in Geneva, Switzerland, and I deal with TB prevention and innovations. So this is a very good opportunity for us to reach out to you on this very important subject. I think it's been a very good introduction to this. There's a lot of interesting data there that has been shown and which shows, I think, a lot of interest in this area. I can see for instance, the lineup of countries that have already digital X-rays, a number of countries using shorter TPT regimens, the subject of what we will be speaking about. So my presentation is going to be focused very much on the recommendations of WHO relating to screening and TB preventive treatment. I think we've seen the definition of screening already. It's the systematic identification of people at risk for TB disease and predetermined target groups by clinical assessment or other special tools. And the word screening is very often used interchangeably with active TB case finding when it's used in a setting to find missing cases. And the other important area is TB preventive treatment, which is medication provided to people, usually with presumed or confirmed TB infection and who are at increased risk of progressing to TB disease or active TB in an effort to reduce that risk, right? And this is also referred to treatment of TB infection, or previously was referred to as treatment of latent TB infection. So the anti-TB strategy of WHO that was launched for the post-2015 era has these two of three pillars that promote the notions of prevention. Active TB case finding and TB preventive treatment are but two components of a bigger framework of preventive action, which include also TB infection control, prevention and care of HIV and comorbidities and health risks, universal access to healthcare, social protection, poverty alleviation, and other action on upstream determinants. And we won't be speaking to all of this today, but we will be focusing very much on screening and TPT. And this is a slide from a modeling work that was done before the launch of the anti-TB strategy, and which shows with this drastic sort of drop that is possible should active TB case finding combined with TB treatment plus treatment of TB infection be optimized in countries and bringing down the level of incidence as it was in the pre-2015 period to levels within the time frame of the anti-TB strategy, using technologies that are largely available at that point in time. I think we've seen this just now, but it's just to re-emphasize the importance of integrating both screening efforts down on the left side of this flow chart with action to give TB preventive treatment to people who are at risk. Very often we see these two things that are not moving in unison. And it is a missed opportunity very often to protect people who don't have TB from appropriate action. The new UNHLM targets that have been issued by countries in late September have also been mentioned. Importantly, the 45 million for new people will be put on TB treatment to be found, and to be found active TB case finding has to be part of the approach. And also 45 million people without TB to be given TB preventive treatment, of which 30 million being contacts and 15 million people living with HIV by 2027. A quick snapshot of the data as global data situation as it was at the end of last year during the update in the Global TB report. There will be a new Global TB report coming out in early November, which will update these numbers. But 2 points to highlight is that we still have close to 11 million incident TB cases every year. So a big opportunity to do active TB case finding amongst people with emergent TB, and also to remember that about a quarter of the world's population shows evidence of having had TB infection. So a big pool of people among whom new TB cases will emerge. In contrast, in 2021, we have seen partial recovery over the severe drop in TB notification in 2020 as a result of disruptions caused by COVID. signifying an important gap between the 6.4 million TB cases who are actually known to have been detected and placed on some sort of TB treatment in 2021 and the 11 million or so that are estimated incidents. And another, I think, emblematic picture from the Global TB report of last year is the progress in provision of TB preventive treatment among global population, showing in yellow bars that most of the people getting TPT are people living with HIV, and even despite the fact that several countries now are putting many TB people living with HIV on TPT, they are still far away from achieving the required level of TPT, much less in the, if you see the green segments of these bars, which show the coverage of TPT amongst younger contacts under 5 in light green, and darker green are the older contacts. So a much smaller sort of contribution to the overall population at risk. Okay, so let's start very quickly about the current guidance on screening. I think this slide has already been shown, showing these two pathways through which people arrive for TB treatment, either from the sort of passive patient-initiated pathway on the top, contrast to the lower, sort of more active provider-initiated pathway on the bottom half of the graph. So the recommendations that we have date from 2021, that's the latest update that we have. You will find a lot of these recommendations are in these, and a lot of what I'm saying are in these documents that we'll point you to. So the guidelines have been published. There are 17 recommendations split between risk groups amongst whom TB screening is recommended, and also new tools and new tools to use in different settings for screening. Accompanying the guidelines are the implementation handbook, which has a very useful practical tool for implementers in order to be able to translate the recommendations into practical action on the ground. So very quickly, I won't go into the individual recommendations, but there are a number of populations who are to be screened using with a strong recommendation for screening. These include the contacts of TB patients, people living with HIV, minors exposed to silica, dust, and prisoners. So these are groups in whom screening should always be conducted. And in these populations, TPT should also be provided to those who are eligible. Most of them would be eligible in many settings, and the monitoring evaluation for outcomes of screening and to inform about the implementation. So these are important elements in amongst these groups. Again, these are other populations in whom screening is condition recommended. That means it is a lesser sort of requirement to screen. However, it's also important to look into these groups, which are numerous in the population, and very often, unless these are also included in approaches to active TB case finding, the numbers of missing cases will not be reached. And so in people with risk factors for TB who are seeking healthcare in settings with a TB prevalence of about 100 per 100,000, you would expect that, or you would recommend that people who are malnourished or with diabetes or a history of previous TB or chronic lung disease would be screened systematically. Other populations with structural risk groups for TB and limited access to healthcare are also recommended. These include urban poor, those living in informal settlements, the homeless, refugees, migrants, and other vulnerable or marginalized groups. There is a lowering of the previous threshold of when to do systematic TB screening in a community. It used to be at 1%, so now it's about 0.5%, which is about 500 per 100,000. In these groups, there is usually a mass screening in the communities that are likewise affected. And also people with untreated fibrotic lesions with X-ray. So for these populations, one would weigh the benefits versus risks of screening and consider opportunity costs for other TB and health interventions when offering TB screening and prioritizing risk groups with the greatest burden. Okay, in terms of tools for screening, so there are a number of tools, each with their advantages and disadvantages. So symptom screening is still there with the WHO recommended 4-symptom screen as being one of the critical ones. And also a combination of any of multiple TB symptoms, particularly in young children with less circumscribed type of clinical pictures, and also cough alone or cough, which is prolonged for 2 weeks or. Then we have chest radiography. I think chest radiography is gaining in importance in TB screening. And this last update, we also have included a new recommendation for computer-aided detection. We will hear more about this in the next presentation from Jake and Zizhen. And also we have added the use of molecular WHO recommended rapid diagnostics tests as screening tools. So this is a first as well. So things like Expert and Ultra and the MolBio TrueNet can be used for this purpose. And also for people living with HIV, C-reactive protein assays would be another way of improving the sensitivity of testing. Again, so this is the recommendation on CAD. Okay, so it is a condition recommendation. It is for people who are aged 15 years and older, used for screening and triage. So it's not a diagnostic, confirmatory diagnostic tool. And the evidence that we have looked at relates to people with abnormalities from pulmonary TB. So, but it's a start, it's an important start, and it has given, way to the introduction, as we've seen now in a number of countries as well. Many countries are using one or different forms of these softwares. More in the next presentation. Okay, so the screening algorithm, so there's many algorithms in our guidelines. So they are sort of organized in these 4 approaches. So there could be a single screening algorithm, right, which is a simple pathway whereby a person at risk is given one test, be it, for instance, cough screening or chest X-ray, and then as a result of whether they are positive or negative, they will go down the route of further diagnostic testing to confirm TB. If they don't, then they will go into another route to assess for eligibility for TB preventive treatment. There also is a parallel screening algorithm approach. So you could have population which at the same time they are getting 2 tests. Okay, this tends to improve sensitivity, tends to find more people who would otherwise be falsely negative. And then as a result of this, they go to the next level for diagnostic testing or as consideration for TPT. It tends to lower, of course, the specificity. So more people with false positive screens would be routed to diagnostic testing. So it might increase costs in that respect. Then there is what we call the sequential positive screening algorithm. That means that in people who have a positive screen, they will get sort of another screening test, right, to before they go into diagnostic test. And this is more specific than, of course, a single parallel approach and more capable of finding people with the highest risk of TB. Of course, it will suffer more on the sensitivity side. And the last one is what we call the sequential negative. So you will have, after the first screening test, those who are positive go for diagnostic testing, and those who are negative are screened again with a second test to make sure that you don't miss any of the false negatives of the first screening tool. And this improves the sensitivity, but and saves resources as well, because not everyone who's positive needs to go through a second test. They go directly to a confirmatory test. Okay, so very quickly about the screening models. So there can be different ones. So there are ones which are sort of based on institutions, be they clinics or hospitals, right? There'll be a place where this is the people at risk are screened at encounter or during a health visit. And then there are also settings which are sort of other institutions which are not health facilities, but where screening needs to be done, because a characteristic of screening is that it needs to be done like TPT. It needs to be done beyond the confines of the usual health facilities, or else even the TB clinics that needs to go beyond that to find people who are at risk of TB, and this would include, for instance, occupational settings, migrant centers, and so on and so forth. And then there are also community type of screenings, okay, be they in the household, a very important focus for screening, be they with mobile, with outreach, with vans, okay, doing campaigns, or else more protracted sort of periods of screening, let's say in informal settlements, and also in community events. And also to finish off this set of slides on screening, just to highlight the importance of, when putting screening component in place in a program, that there's a proper attention to these critical instances in the planning cycle, to start with a proper assessment of what there is, what there needs to be done, setting goals, then identifying these priority risk groups, choosing the algorithms that should be prioritized for certain groups, okay? Planning, budgeting, monitoring, evaluation, and then implementing change in the next sort of the next role of this cycle. Okay, so I'll go over to the guidance on TB preventive treatment, just as displaying here in a kind of smart way the cascade of TB preventive treatment. Our guidelines for TPT relate to 2020. They are split into these 4 sections. There are 18 recommendations right now. They are focused on identifying people at risk, ruling out TB disease, testing for TB infection, and different options for TPT regimens. You will find the recommendations highlighted over here. With the guidelines, as usual, in the consolidated series of guidelines, we have accompanying operational handbooks, which give implementation guidance for setting in place these recommendations. So in terms of people, very quickly, people who are at risk in whom TPT is recommended. So the first 2 are strong recommendations for in people living with HIV who are aged 10 years, more than 10 years. And in these people, TPT is always recommended regardless of ARV, whether they are or are not on ARV, whether pregnancy, previous TB treatment, immunosuppression, or availability of a test for TB infection. Okay, and also infants aged under 12 months who are in contact with TB. So in these groups, you always give TPT. Then there are other groups in whom TPT is condition recommended, children aged older than 12 months in a high TB transmission settings, and all children who successfully complete treatment for TB disease. The next group are the contacts. So children under 5 years, the TPT is recommended, regardless again of testing or availability of tests for TB infection. And also there's condition recommendations for individual aged contacts aged more than 4 years. There is another recommendation on treatment of TB infection in people exposed to multi-drug resistant TB. This recommendation will be revised later this year by WHO, and we expect new recommendations and new updates to these guidelines that came out in 2020 in 2024. Then there are other risk groups mentioned in our guidelines. So there are other risks which indicate a strong recommendation. These include silicosis, start of anti-TNF treatment, or dialysis, and preparation for organ or hematological transplant. So these groups you always assess for TB infection, TB disease as well, of course, and give TPT accordingly. Then there are other groups in whom systematic testing and TPT is also recommended conditionally. These include people in prisons, healthcare workers, immigrants for countries with a higher TB burden than the country of resettlement, homeless people, people who use drugs. And then finally, there is a list of other groups in whom TPT is or systematic testing and treatment is not recommended. So these include people with diabetes, people who use alcohol, tobacco smokers, and people who are underweight. So in these groups, these are not absolute contraindications for TPT. TPT can be given, but the evidence does not support the use of TPT. The use of TPT systematically, as you would do, let's say, in people in other groups. Okay, so this is the point. But if there are other circumstances in which predispose these people to risk of progression to TB, then you could use TB. Okay, so ruling out TB disease. So this is part of the screening that we have discussed. So, but with a bit more sort of pragmatic approach to what to do. So in people living with HIV who are older than 10, who do not have any of the 4 symptoms screened, the current cough, fever, weight loss, or night sweats, they are unlikely to have TB disease, and one can start TPT immediately. So, and again, if any of these occur, then you would not give TPT before you evaluate them for TB or other diseases. Okay. Chest radiography may be offered to people with HIV on ART, and TPT given to those without abnormal findings. So this is a condition recommendation. And another strong recommendation is about infants and children who are under 10 years, who have poor weight gain, fever, current cough, or have history of contact with a person with TB, should also be evaluated for TB or other diseases. The principle that in younger kids, the clinical picture may be less circumscribed. Okay, so for household contacts of pulmonary TB, the absence of any symptoms of TB or the absence of abnormal chest radiographic findings may be used to rule out active TB disease amongst HIV negative household contacts aged 5 years or more, and other risk groups before preventive treatment is given. Okay, then there is the next step, okay, which is the 3rd step in the cascade, and this is about the testing for TB infection. So there is a recommendation to use either TST or IGRA for TB infection. It used to be these 2 brands of IGRA at the time that this recommendation came out. Now I'll show you in the next slide, this list of tests has been expanded. And also last year, we added the new antigen-based test, skin test for TB infection that can also be used for this purpose. Again, just what we mentioned before, that tests for TB infection are not required when initiating TPT in people with HIV or those who are aged under 5 years who are in contact. Okay, so this is the list, okay? See it very quickly. So there are new brands of IGRA that can be used now, and these 3 brands of antigen-based TSTs or TBSTs. Okay, so this is just to show you the algorithm that's in our guidelines. They will be updated. It shows these 3 entry points for people, and on the basis of where they place in terms of results of either symptoms or else other screening tools and TST or IGRA, then they could go into different routes of investigation. And finally, this step of the 4th point of the cascade is the TPT options. So these are the options that are mentioned in our guidelines. So there's the 6 or 9 month daily isoniazid, the 3 months of weekly isoniazid and trifapentine 3HP, 3 month daily isoniazid rifampicin and 3HR, 1 month of daily isoniazid and rifapentine or 1HP, 4 months of daily rifampicin, and also in some settings, not maybe in the region of PAHO, where you want to give more isoniazid in people older than 10 when you have very heavy high TB transmission. And the last one is about the treatment for MDR-TB exposure. I think 6 months of daily levofloxacin is already mentioned in our guidelines, plus or minus other drugs, okay, usually 2nd-line drugs. Okay, so just very quickly, I don't have more. I know that I may be over time now, but just some resources for TB screening and TPT. So these are 2 tools for screening. The Screen TB tool, it will be an update of the older tool that was launched a few years ago. So it will be now on a platform. You're seeing a sneak peek over here of how the interface will look like. And it will be coming out very soon. My colleague Cecil Miller, who works as the focal person on screening here at HQ, is working very hard to have this out in a few days' time. And the lower part is the the utility for calibration of CAD. Okay, so this will also be the subject of the next presentation. This is another tool that we use for monitoring evaluation of screening and TB preventive treatment. It's called the Prevent TB tool. It started its life about 6 years ago. Now it's in a new sort of format as well since a few years. And this tool is meant to display to countries the type of data that needs to be collected in order to monitor the cascade of TB preventive treatment. It is not meant solely to be used as an app. You can integrate these functions better still into an existing HMIS that you have, or else DHIS2 is another tool that's being used, an open source tool that's being used by many countries. And these data elements can be inserted. It also shows illustrates how dashboards can be built to illustrate and monitor key indicators. Okay, so again, I point you to the TB knowledge sharing platform. This is another tool that we launched 2.5 years ago, and it groups together the guidelines, handbooks, as well as training modules. So I did not mention the training modules before, but please visit these tools. We are expanding the availability of different documents also into Spanish. So both the TPT handbook and the screening handbook are available in Spanish. Okay, so you can access these directly. And also the knowledge sharing platform has this very potent quick search function where you can put terms over here and find them directly, or else use these pre-established buttons down on the right side to find specific key populations or areas of interest, okay, as you can see in this site. There is also this website that you can visit to find the individual recommendations. It's only in English, but you can find if you just want to know about the recommendation, its text, its strength, and the evidence that is around it, then you can use this tool to go there as a information. Finally, the training modules. So you find there are 2 training modules that you can follow. Again, they are in English right now, but the language translations are coming quite soon. Okay, so in terms of key messages, so again, the decline in TB notification post-COVID has only partially recovered. So active TB case finding remains very important. Just to remember, TB prevention is very interconnected. So early detection and treatment of TB is also important for infection prevention and control. We had not had the opportunity to discuss IPC. Maybe in another meeting we can do that. People at risk who screen negative for TB may benefit from TPT. So an important message, I think. Very often it's forgotten. TPT coverage remains poor in contacts and very poor and still low in people with HIV. So it's still not there yet. There is a new threshold for wide-scale and community screening that was set up in 2021 at 0.5%. So keep that in mind. New screening algorithms favoring more sensitive tools are coming up. More importance given to chest X-ray, use of CAD, right, to improve the access to interpretation of chest X-ray findings. There are new tests for TB infection, shorter TPT regimens to facilitate uptake and adherence. There's TPT for MDR-TB, protect contacts. We will review the guidelines later this year. And of course, the new UNHLN targets, which inspire us to do better work until 2027. Okay, so with that, I would like to thank the many people who have done all the work that I had the privilege to present to you, as well as all our partners that are listed here. I hope I mentioned some of the more important ones, but I'm sure I missed some of them as well. Thank you very much.